I'm going to take you through an actual application of deep neural networks that I was involved in, where we worked on a heart failure deep neural network in conjunction with Washington University and Barnes Hospital. This resulted in a publication for the JACC Heart Failure Journal, which is part of the American College of Cardiology Foundation, published by Elsevier. So the title is Electronic Health Records, so EHR, Deep Learning Prediction of Death or Severe Decompensation in Heart Failure Patients. You can see the research team that I worked with there listed. It was a great opportunity for me to work with a lot of people that have very real clinical knowledge and expertise. I was bringing mainly the machine learning and deep learning aspects to this research project. So the background: surgical, mechanical, ventricular assist, and cardiac replacement therapies. So considerable intervention into heart failure, be it a transplant or considerable adding a device to assist with the heart function, is life-saving in many heart failure patients, but remains high risk. Despite this, the difficulty in timely identification of medical therapy non-responders and the dire consequences of non-response, not doing anything, have fueled early, less selective surgical referral. So you want to really be sure that it is actually necessary before you intervene at this level surgically with these patients. Patients who would have ultimately responded to medical therapy are therefore subjected to this risk and life disruption of these major surgeries. The purpose of this study was to develop deep learning models based on commonly available EHRs that are available in many hospital administration systems like Epic and Cerner here in the United States, variables to assist clinician in timely and accurate identification of heart failure medical therapy non-responders. So targeting who would benefit most from such intervention. The results: we had access to a really neat data set for this. It was nearly 80,000 distinct admissions from 52,265 heart failure patients met the criteria for inclusion in the study, and this resulted in over 350 million EHR data points. For model training, validation, and testing, 20% of the model observation were positive, and the result from it, the binary classification, the C statistic or the AUC, was 0.91, which we were quite happy with. Now, I do need to also point out this data is very protected by HIPAA and is personal information on these individuals, like you see in many of these medical journal publications. So the data is not available. It was used for this study. The code similarly only really works on this data and therefore was not published as well. But I'm going to give you some of the techniques that I made use of as I went through this particular study. And the conclusions: the demonstrated accuracy of the EHR-based deep learning model, prediction of 1 year all-cause death or referral for heart failure surgical therapy supports clinical relevance. So this does potentially have some use in predicting responders and non-responders of these particular treatments. Technologies that I made use of: Pandas. Pandas is used to do all of the pre-processing on this data to get it out of the form of the actual administration system and into a form that can be used in deep learning. This was a fairly time-intensive part of the process because we made use of just CPU-based pandas, and this is something we're looking at possibly advancing in the future, perhaps rapids. Deep learning was done with an NVIDIA RTX A6000 that NVIDIA was very kind enough to donate to this channel for my use. I also was able to use it in this project. It's running on that machine behind me, so I was able to run all this non-cloud and keep within the parameters of the data we were protecting. We made use of Word2Vec to encode a lot of the natural language processing human text strings that were in this data. We'll get to that in a moment. And fundamentally, this was a Keras neural network with LSTM layers and components. It was an ensemble neural network approach. Again, we'll see what that looks like in a moment. This is the central illustration that was in paper. You can see the electronic health record information coming in, being presented to a deep neural network model. And then in a more production type situation, you can see the AUC curve there, but a new patient would come in and the deployed model would give you what is the overall risk of a 1-year decompensation. So experiencing heart failure where some sort of intervention or death was the result. And the positive label for this was severe heart failure that was intervened by a particular surgery or death resulting from within a year of when the particular data point occurred, and the data points occurred at each admission to the hospital, be it for tests or be it for an actual procedure, or even a clinic visit. This is the ensemble neural network structure that we made use of. We had time series data and patient attribute data. The time series data, there were really 3 components that come into the 3 ensemble input layers. The first input layer is what I call the unstructured data. This is data that is the prescriptions, the procedures that were performed on the patient, diagnoses, surgeries that were performed, all of this kind of information that might be named differently across hospitals and potentially even regions. So this was specifically targeted at the US. That allows then, when this is generalized beyond just Barnes, that potentially we could take the same sort of textual data, feed it into the same input layer, and Word2Vec, which is building these 32 sized vectors of 100 sequence, so 100 last values coming in, that does increase the generalizability of this model. And the unstructured data is where we got the most amount of lift for the overall model. We also had labs, which was obviously very important data being fed into it. For this, we identified 70 of what we considered to be the most important labs. And these were picked by a medical doctor with considerable background in cardiology and cardiac surgery, cardiothoracic surgery. These 70 lab values were also very sparse because not every lab is performed on every patient. We'll talk about how I filled in the gaps there later. And it's not your traditional sort of missing data scenario. In C1, the input layer here is vitals. Similarly, the subject matter expert chose the 7 vital signs that were the most important to this. We'll see those 7 in a moment, and the complete list of 70 labs are shown in the paper. I will show you some of the top ones in a moment. And for all 3 of these, the sequence size going into that LSTM is 100 values. We did some experimentation there, but 100 seemed to be enough that there was enough data to be there that some prediction could occur. Then we also had 7 static variables. These were simply for the patient. We used age, gender, race, length of stay for the particular admission. So these are staying the same for the individual admission. And then there's also some engineered values like the total number of records that we have as of this admission. Then all of these fed into a dense neural network that outputted 1, where the positive label is within a year of this admission, they had died or decompensated, faced severe intervention. 0 meaning they were okay. They did not face death or severe decompensation. So let's also talk about how I encoded the labs and the vitals. Particularly the labs, although exactly the same technique was used for both. We have very sparse data. Some of the vitals are only there if the person is actually admitted and undergoing telemetry of some sort where there's a lot of data coming in at fairly high frequency. Simple clinic visits would not result in that sort of level of detail. Labs, not all patient is going to have all 70 of those labs, and that's not really missing data per se, where the value is there, we just have to extrapolate it or impute it. So what I did for this was to basically take, say, the labs where we have 70 some odd labs. These are all z-score encoded. So 0 means exactly at the mean, and then 1 would mean 1 standard deviation above the mean, and -1 would be 1 standard deviation below the mean. So this vector, all 70 of them, starts out as all zeros, meaning completely mean. I'm using 0 here, not even so much to represent the mean, but to represent to the neural network that this is unremarkable. There's nothing particularly going on here to see. Nothing to see, move on. And then as future time slices come into that sequence, say for example, 3 labs come in at one time slice, now those 3 zeros are going to be replaced with these lab values. And the lab values for those 3, those will continue to propagate further. We have a few more time slices go by, the 3 will simply replicate. They will replicate now until that patient has a new value for that particular lab come in and replace it. Otherwise, they stay the same. And then maybe other labs come in that are not in the 3. Then you will see those values fill in, and it just keeps replicating forward. The lab value stays until there's another lab value to replace it. This seemed to fit the model really pretty well. It gave it decent lift. And ultimately, if it was a not as good technique, we would certainly have seen a drop in the overall accuracy of it. The same exact technique was used on the vitals. However, there's only 7 vitals, so and not nearly the degree of sparsity that we had, but overall, we used exactly the same technique where as new vitals were collected, they replaced the previous ones and we copied forward just like we did with the labs. Feature importance is very important in these sorts of models. Here you can see the 7 static values that we were capturing for the patient's vitals and also the lab values. The lab values you're seeing here are the most important ones that were contributing the most to the overall accuracy of the model. And the bivariate approach that I'm using here lets you see how important they are together. For example, the BNP along with systolic is the most important pair. You can tell by the heat map overall how the importance then falls off, particularly looking at the interaction of these two together. That very much helps us know how to further engineer data to get better results. Overall, I was very happy with the results from this, and it was accepted through peer review for publication in JACC, so I was quite happy with this. I've not published. This is my first medical journal publication, and I very much thank the team at Barnes for including me into this and teaching me a whole lot about their field of considerable expertise. Hope to be able to find other projects in the future. Future directions I would look at for this kind of data is investigate end-to-end GPU processing. Running that data through the preprocessing and pandas is considerably slow. It took over an hour typically just to observe individual changes. I'd really like to get this into end-to-end GPU processing, and NVIDIA has been very helpful to my channel with supporting additional GPUs for me to make use of in this technology. So definitely looking at getting this converted into Rapids. You'll probably see some videos from me on how you take pandas, especially fairly complicated pandas, and get it converted over so that it works in Rapids. Maybe look at PyTorch as an option to Keras, and transformers for some of the NLP as opposed to the LSTM layers that we are currently looking at. Other targets might be interesting as well. Other things that the clinicians would really like to predict in this type of data. So long as there's sufficient signal in the data to support prediction, other things may be possible as well, and who knows, if additional data is available, other things can be looked at in addition. Thank you for watching this video, and if you would like to see more on Rapids and PyTorch, which are some of the things that I'm going to be looking at with this real soon, definitely let me know in the comments, and give me a like if this video was useful, and subscribe if you'd like to see other related videos. Are you interested in medical data and medical application? Definitely let me know. There are certainly opportunities there.